Welcome to Life Beyond Tax. Our guest today has led a colorful life. With a few steps, he has accomplished a journey others may take across lifetimes. He has broken smuggling rackets at the airport. He has curbed the illicit trade of narcotics and contraband in sensitive border areas. And he has even advised the Government of India on trade security and tax policy. As a bright young officer in the Indian Revenue Service, he has held important and responsible positions over 15 years in the Government of India, Department of Revenue, Customs and Excise. He went on to study public policy, global health and administration in America, and he has even lectured on global health problems at the University of Chicago. Mr. Sandeep Ahuja is the founder and CEO of Operation Asha, the health NGO which works for TB patients in India and Cambodia. He set up Operation Asha with his colleague Dr. Shelly Batra. Together, their dream is to eradicate tuberculosis from India and the world. Let's meet Mr. Sandeep Ahuja, tax commissioner, lecturer, book writer, and now social entrepreneur. Mr. Ahuja, welcome to Life Beyond Tax. You have been a commissioner, you have been a teacher, you have been a lecturer, you have even written a book, and now you are on to something totally new like social entrepreneurship. Which cap has been most exciting?
Well, each one of them. My life reminds me of Van Gogh. 200 things, including working in a coal mine, before he actually started painting. And we know him only for his painting, right? He was looking for his vocation. So I've done many things, I've donned many hats, and here I am. I love what I'm doing, and that is how the journey has been.
So, you have studied public policy, health, you have studied administration. So, why TB now?
But I'll take you back to one of my days as Undersecretary in the Ministry of Finance. I remember very clearly a meeting after lunch where 7 or 8 of my colleagues were present. And we were just discussing, who had done what. Someone commented that I had been very successful. However, I remember going into a thinking mode and saying, oh, I don't agree. I don't think I've been successful. Unless you do something that improves the life of the poorest of the poor, the last man on the street, you haven't really done your bit. So I said, no, I have not been successful. In spite of everything I might have done, I'm a failure. And I wanted to move on from that failure.
You have been nurturing these ideas of altruism and wanting to do something for the last man standing. But why TB? Why tuberculosis?
This is neither altruism for me nor sacrifice. This is what I love to do, and that's it.
Wonderful.
First thing. Now to your question, why tuberculosis?
Yes.
Dr. Shelly and I used to do some work together. She would operate on poor patients for free, and I would help her raise the funds. When I went to the US, I realized that the size of the philanthropic market in the US is simply huge. In India, for us, philanthropy is a side hobby, not even a main hobby, right? That is when I spoke to Shelly, and very kindly, even though she's a gynae surgeon, she agreed to partner on a big public health issue in which we could leverage our funding with, say, funding from the US and make a much bigger difference in society. Then, when we looked at various big public health issues around, HIV/AIDS, there were lots of big organizations working on it, including the Gates Foundation. Polio, nearly done by Rotary. Malaria, more of a sanitation problem. TB, nobody's business. Even today, the funding for TB from international donors is about 20 times less than the funding for HIV. A person dies of tuberculosis every 90 seconds in this country. However, I have met very senior cabinet ministers. I have met MPs from districts which are famous for the high incidence of TB who have interrupted me and told me my data must be wrong. That there is no TB, that there's not a single case in either their state or their district. It's a shocking state of neglect. So that was the reason we picked up TB. The second was in TB, the government of India provides unlimited medicines. Now in healthcare, you have free medicines. It takes care of 60% of your expenses. So without even knowing, the government actually had a promise and has been fulfilling that promise of funding our NGO to the extent of, say, about 60%
Wonderful.
from day one. So these were the key reasons why we got into TB.
How serious is tuberculosis? Which is the country with the maximum number of TB patients?
According to Government of India's estimates, India has 22 lakh new cases every year, more than twice the number in China. Unfortunately, we lead the pack when it comes to numbers of TB patients. Not only that, we are also leaders when it comes to number of patients of drug-resistant tuberculosis. As a matter of fact, we are the only country which has detected so-called totally drug-resistant tuberculosis. We are bad. It's a ticking time bomb.
Why hasn't the government program on TB been effective?
The fact is, it caters to something like 15 lakh TB patients every year. Of all the disease programs in the country, it is the best disease program in the country. Allow me to compare our program with Bangladesh, a country which is far lower on GDP, on per capita income. It is far poorer. However, their TB incidence rates are much, much lower than ours. The reason is that the governments, the bureaucracies, were never devised, they were never designed for delivery of services. They were designed to rule. They were designed to follow and lay down laws, rules, practices, precedents. They were not supposed to be in business of doing business. It's not meant to do business. It's not supposed to have the flexibility that you need to deliver a health service or any other service.
So you would say that for a government program to work, a government needs to collaborate with a private party.
Absolutely. See, how does it work in Bangladesh? Again, allow me to go back. The entire top bureaucracy, all the doctors, the entire ministerial staff, they are government staff. However, you walk into a lab. Half the technicians belong to NGOs and half to the government. You go into the field, there's no government staff at all. Who deals with the patient? The NGOs, the NGO staff. My people are paid rupees 225 per new enrollment. You perform or you perish.
So there is an incentive
to do every key activity. There's an incentive to enroll new patients, not just find them. If you find a patient and if you don't treat, what's the point of finding the patient?
True.
It's probably worse.
So identify and bring into the program.
Bring into the program, number one. Then TB requires a lot of doses which should be supervised by the health worker. For achieving 90% of that number, again, we give 500 rupees every month. Then we have a minimum treatment success rate of 82%. If someone doesn't achieve that for 3 months running, he or she is terminated. Can the government terminate? Governments are not meant, they're not designed to do this. So the government should keep the bureaucracy. They should retain the political leadership. They should retain the funding. They should retain the middle management and the doctors and the labs.
When you set up Operation Asha, it became the first organization to use simple and cost-effective technology, especially the biometric handheld devices. How did you come across this idea?
Well, I think it is simple. When you do something, you have to keep your ego out. You're not the best judge of how things should be done. We've only done what our patients asked us to do. Imagine that a patient has to come 60 times over 6 months, meet my health worker, or my health worker has to go to him, feed him the medicine in his presence, come back. If they're unable to meet for certain reason, then the health worker has to follow up with him on the phone or with a personal meeting, provide him further counseling, and bring him back into the system. If that is not done, the patient defaults. Statistically, half the patients who default will become drug resistant.
That's right.
The length of their treatment will go up by 4 times, from 6 months to 24 months. Worse than that, the cost of their treatment will go up from a few thousand to 2 lakhs at least. Where is that money coming from? This person is not going to get treated. The mortality rate is 80%. He's going to die. Worse than that, each TB patient infects 12 others before dying. So he's going to infect 12 others with the drug-resistant strain. He has become a messenger of death. So, the first thing is, if you do TB, you must reduce your default rate to actually 0. Right? Do humans have that kind of integrity? Obviously not. Will our patients be so truthful? No. What will be our default rates? What am I doing? Even with a 10% default rate, believe me, Asha, I'm actually hurting the society by creating more drug resistance than the normal TB I'm treating. I should shut down my TB program. The only way to manage all this well and keep my default rate low and actually know the truth, I had to develop some technology. So finally, we were able to tie up with Microsoft Research, and they developed the technology pro bono.
Alright.
And that is how we started with the technology.
But isn't the government of India introducing biometric devices into their administration of the TB program?
No, not in the TB program yet. They're doing it for attendance, they're doing it for many things.
And I also find that Operation Asha has set up its centers, say in a doctor's clinic, in a little area of the doctor's clinic, or even in a temple. Why is that?
Many reasons. Who are you and I to treat TB? It's the community that serves community. That is our mantra. So it's the community serving the community. We are partnering with them. That is the key reason why it is the temples, why it is the phone booths, why it is the local medical practitioners.
And Operation Asha is working in India and in Cambodia. What is the difference you find in operations in both these countries?
I'll give you a simple example and that'll explain everything. In Cambodia, when we were 2 years old, we wanted to expand to a new province. We did our homework, we were allowed to. Now, one of the things we do in every rural or tribal area is the labs are far away. So, what we do is we tie up with lab technicians and our workers collect samples from the villages and transport them to the lab on a day that the technician is there. It practically takes the labs to the patient's doorsteps. That makes detection far more easy. Now, in the second province, we were told, no, this is not allowed. Now, the local staff, which is mostly Cambodian, asked my permission to speak to the national TB manager, which is the head of the national TB program in the country. And I was like, no, hold on, this will be treated like a complaint. Please try and convince the district officers and the provincial officers. Finally, after 20 days, I relented and I thought I'd taken a huge risk by allowing my country director to report to the national leadership that our workers were not being allowed to transport sputum in that province and in those districts. I was so afraid, I can't tell you. I thought our TB program in Cambodia might be shut down. So our country director writes an email to the national TB manager. Believe me what happens. Actually, it's unbelievable. Within 7 minutes, I'm repeating, within 7 minutes, we get an email back from him which says, I've spoken to the provincial director and the district director. Transporting sputum is now part of national guidelines. Next paragraph. If you still have problems, get back to me. We are partners in it together. 7 minutes. Nobody would get an acknowledgement in 7 minutes in India.
And how is this different from India?
India, as I said earlier, the things are much more complicated. There are many levels of governance. So, in spite of a model that has worked so well, we still serve only 0.5% of the Indian market.
And how many centers do you have in India?
Right now, about 250.
Okay. And 125 in Cambodia. Wonderful. And
then there are others in Kenya and Uganda and the Dominican Republic, which are not formally our centers because we do not have our own staff there. So all the work there is done by local NGOs whom we have trained on our methodology and technology.
And what are the challenges you see for Operation Asha, say in the next 10 years?
If you ask me, it has been very good going. So we started with tuberculosis. However, in the very first year of our existence, a senior consultant from McKinsey said, Sandeep, what you have developed is a delivery pipeline. It can be used to deliver any products and services to the bottom of the pyramid markets, to the disadvantaged communities. Now, we deal with 4 or 5 diseases: tuberculosis, hemophilia, heart care, diabetes, and mental health. So we are not just into TB. So it's going to become a comprehensive pipeline. Now the only thing we are waiting for is how soon we can apply our model to entire healthcare, provide very high quality care to the villages and slums, and connect them for complicated cases to the secondary and tertiary centers, and cut out the entire chain of unqualified medical practitioners. That is what is going to happen. One. The second thing I'm waiting for is the day when in India we will not have a single missed case of TB. Right now there are 7 lakh unknown, undiagnosed cases every year who go on infecting others. So that will be my second target. The third will be the day when our technology and strategy will be present, say, in 20 countries. And then finally, across the world.
From commissioner to social entrepreneur, when you look back, have you really got what you wanted?
More than that, did I leave a void in the tax system of the country? No. Right? Without me, the department continues to do as well. Or as badly. Whatever way you want to look at it.
I must thank you for being with us, and we wish you all the success in your journey ahead.
It's a pleasure and an honor. And I must say, the real success will lie if I can make some people in the tax department and maybe in the health department, in the government of India, and possibly governments across the world, develop better policies and programs and implement them better for our TB patients. And if together we can save many more lives than we do today. Thank you.
Sure. Thank you, Mr. Ahuja.